Thank you for following along with the lecture so far. Let's take a step back and review the entire outline. We've covered Chapter 1, Section 1 up to this point. Next, we will carefully examine the premolars and molars in the 20s, employing the exact same methods as before, and by doing so, Chapter 1 will be fully completed. There are a total of 4 chapters, and if we break it down by sections, there are 12 sections in total. I imagine you can anticipate the long journey of the upcoming lectures. However, if you practice in your dental clinic and stay motivated while listening to the lectures, I'm sure it will bring beneficial changes to your actual dental practice. Furthermore, because the identical principles and logical reasoning we have already covered will be reiterated, if you have diligently followed the instruction thus far, the subsequent lectures will progressively become more recognizable and straightforward, simultaneously enhancing your comprehension of proper posture through a profound synergistic effect. Alright, let's proceed now to Section 1, which specifically addresses the premolars in the 20s. Next, we'll now examine the occlusal surface of tooth number 24, which is a premolar in the 20s. For the tooth axis, we look at parallel alignment, starting with the category of grasping the suction. Since this is a maxillary tooth, the chair position is adjusted to the spine mode, with the patient's body parallel to the ground. The patient's head is tilted back as far as possible, with the chin pointing upwards. To get a clear view of the 20s, we rotate slightly to the right. For tooth 24's Wilson curve, the practitioner should position themselves at approximately 11 o'clock. This allows for proper alignment of their body and line of sight, ensuring they are perfectly parallel to the tooth's axis. Make sure to spread your legs wide apart and then place your right foot firmly on the pedal. Back normal, practitioner's neck flexed forward. When preparing the maxillary occlusal target area, in contrast to prepping axial surfaces like the buccal or palatal aspects, the practitioner's neck will undergo a considerably pronounced forward flexion, which is quite significant. Consequently, as the target area shifts from premolars to molars, preparing the maxillary occlusal surface typically demands a greater degree of forward flexion in the practitioner's neck. So, for occlusal preparation in the posterior region, it's often more advantageous to approach from a perpendicular alignment rather than a parallel one. When the handpiece head is positioned buccally, the volume of the suction tip at the left corner can overlap and interfere with the handpiece head. Therefore, there's a technique to move the main body of the suction tip aside to the depth of the vestibule in the 20s. Let's observe this now. Alright, at this point, because the volumes are overlapping, you should insert the suction tip held in your left hand deep into the vestibule. Subsequently, the handpiece head then moves to the exact original position where the suction tip was located. Let's observe this once more, just like this. This way, the left and right hands organically work together in perfect harmony, which is the very essence of two-handed dentistry. When prepping the occlusal surface, there are 2 approaches. One is when the handpiece head is positioned buccally with the burr facing the opposite direction, and the other is when the handpiece is positioned palatally. In each case, the posture of the hands differs. For the palatal aspect, the left hand's 4th and 5th fingers rest on the left zygoma, while the right hand's 4th finger rests on the premolar area of the upper right quadrant. For the buccal aspect, the right hand's 4th finger moves to the anterior teeth instead of the premolar area for support. Furthermore, in the palatal aspect, the right hand's wrist shows only a slight flexion, but with the buccal aspect, the wrist bends more significantly inward due to alterations in the rest and handpiece grip. This wrist flexion is not problematic when performed intermittently or briefly, but maintaining this static posture for extended durations can be detrimental to your wrist health. Considering the principles that you've heard from our previous lectures, how might one effectively address this wrist flexion problem? The most appropriate and effective solution to this issue is to make suitable adjustments to the higher level elements of posture, thereby preventing the wrist from excessively bending or flexing during the occlusal preparation procedure when working on the buccal aspect. For example, you might need to adjust the patient's head position, the operator's body position, or experiment with different alignments, such as perpendicular instead of parallel. The content and structure of this seminar I'm teaching you are based on various posture elements I've personally tested and verified through extensive experimentation. Now, let's take a closer look at the occlusal preparation in both the palatal aspects. To ensure proper visibility and accessibility in the palatal area, turn the patient's head slightly to the left and move the operator's body to the 10 o'clock position. You should place the rest of your right hand on the masseter or the chin area on the right side. In this slide, the rest of the right hand is not fixed. When prepping the palatal action surface like this, the rest of the right hand should be on the masseter, and the handpiece grip should be parallel to the oral cavity. Thus, when preparing the occlusal surface, it is important to observe that the handpiece grip should enter perpendicularly to the oral cavity surface, and the rest of the right hand should shift from the masseter to the mentum. The grip of the handpiece is a very important ergonomic factor, and frequently, by making creative adjustments to the grip, the stability of other ergonomic elements can be significantly improved. Here, you can see a scene of prepping the occlusal surface from the buccal aspect, where the flexion of the waist and neck is involved. Thus, it's much. It's excessive. Let's watch it again. It's excessive. In situations like these, as it involves a more fundamental and higher level posture, it becomes essential to re-evaluate core elements such as the patient's head placement, the operator's body positioning, and the specific methods of alignment. As previously indicated, within an identical procedural setup, the upper image illustrates the execution of an occlusal preparation from the palatal aspect, whereas the lower image demonstrates the performance of the same occlusal preparation from the buccal aspect. As you can see in the photo, highlighted by the red area, when performing an occlusal preparation from the buccal aspect, there is often excessive flexion of the waist and neck. In such cases, you need to reconsider the fundamental approach. For example, it's better to position the practitioner's body at 2 o'clock rather than 10 o'clock. Alternatively, rather than aligning the instrument nearly parallel to the tooth's central axis, it is significantly more beneficial to position it precisely perpendicular to the left of that axis. In numerous instances, when particular body positions lead to significant stress on the lower back, neck, or wrists, it is often possible to alleviate that pressure on the lumbar region, cervical area, and shoulders by modifying more foundational or elevated postural elements. Furthermore, as previously stated, when preparing the palatal axial surface, the right hand's rest is positioned on the masseter. However, when preparing the occlusal surface, the handpiece grip and approach angle are altered, causing the right hand's rest to move to the mentum. Please carefully examine and contrast these two images to observe this phenomenon. Now, let's observe the preparation of the buccal surface on tooth number 24. The patient's neck should be rotated to the right side to ensure proper visibility and access to the buccal aspect. At this point, the practitioner's body is at about 11:30. It doesn't greatly hinder visibility or access, but it's a bit uncomfortable. So, approximately midway through the video, you can observe the practitioner repositioning their body from an initial stance at 11:30 to a more stable and ergonomically sound position at around 12:30, optimizing their working posture. Let's look at it again. We are readjusting the position from 11:30 to 12:30. So, early in the video, as we saw before, the practitioner's body is positioned around 11:30. While this setup isn't particularly problematic, it does make it a bit difficult to get a clear view and ensure proper instrument access to the buccal aspect of the 20 teeth. Therefore, by slightly readjusting to around the 12:30 position, the practitioner can achieve a significantly more stable and ergonomic posture. Now, let's look at the prep of the mesial and distal contact surfaces approached from the buccal side of tooth number 24. To get a clear view of the distal contact surface, the patient's head is turned to the right. The practitioner's body is positioned just a bit clockwise from 12:30, approximately around the 1 o'clock position. In this specific situation, if the secondary curve of the suction tip is angled toward the outside rather than inward, the suction tube will more easily and naturally align itself in the maxillary region. By effectively using the volume provided by the suction tube when it's in this particular position, you can effectively retract the corner of the mouth, which significantly aids in obtaining a much clearer and unobstructed view of the distal contact surface during the procedure. This is how you retract. I want to emphasize this once more. as there is a valuable secondary application for this suction tube right here. Compared to the anterior teeth, when prepping the posterior teeth, the corner of the mouth can sometimes limit your view. In this case, slightly retract the corner of the mouth outward using the volume of the suction tube, which will be very helpful. Now, let's examine the prep of the mesial and distal surfaces from the palatal aspect of tooth number 24. For a clear view, turn the patient's head well to the left. The operator's body should be at 10 o'clock. Hold the handpiece with a long grip and rest your finger on the right masseter muscle. You should rest your left index finger and your thumb on the left zygoma area while holding the suction with your left hand, firmly gripping it. For the palatal distal preparation, while parallel alignment can indeed be utilized, a perpendicular alignment mode offers superior visibility. In this lecture, I will introduce as many posture types as possible, but you will gradually learn that some modes are less suitable and others more suitable, depending on the target tooth and area. Another important point to mention is that while we conceptually distinguish between parallel and perpendicular alignments within this lecture, in actual clinical practice, there can often be ambiguous intermediate points existing between these two distinct alignments. However, for systematic explanation, please understand we utilize these conceptual terms. The fundamental criteria for posture will be which one best allows you to maintain health, ensure visibility, secure accessibility, and protect surrounding tissues in each specific situation. Observe here a demonstration of shifting the hips on the chair, moving from the 2 o'clock position all the way to the 10 o'clock orientation. This maneuver is essential for optimal positioning. The typical operator stools, those that come with a backrest and are usually included when you purchase a dental chair, are often quite heavy and cumbersome to maneuver. I strongly advise acquiring more economical hospital-style stools from online retailers such as Coupang, as these can be effortlessly repositioned using just the friction generated by your hips.